네, 안녕하세요. 서울 뿌리 깊은 치과의 조용진 원장입니다.
Greetings, I'm Dr. Choi Young-jin of Seoul Deep Rooted Dental Clinic. Today I'd like to talk about design of posterior implant prosthesis. We frequently encounter cases requiring 1, 2, or quadrant design implant restorations. Today I'll share the principles that we should follow in designing these restorations. When it comes to designing posterior implant prosthesis, there are various factors to consider. The buccolingual and mesiodistal dimension of the crown, the form of the occlusal surface in contact with the opposing arch, marginal ridge, proximal contact, gingival embrasure space, subgingival contour, and emergence profile. I'll address them one by one.
이렇게 나눠서 생각해 볼 수가 있겠습니다. 하나씩 차근차근 말씀을 드려보도록 하겠습니다.
First is crown dimension. As for mesiodistal dimension, it is often naturally determined by the adjacent teeth, meaning there is not much to ponder here. When working with one or more implants, mesiodistal width is determined by the distal surface of the mesial tooth and mesial surface of distal tooth. When making implant restorations for one or more implants, if there is a distal tooth, the mesiodistal width is determined and the prosthesis size is determined accordingly depending on the implant position. You can adjust the tooth size accordingly, and you need to make sure that the implant screw hole comes out in the middle of the implant restoration. We need to give buccolingual width a little bit more of a thought. There's buccal occlusal line and lingual occlusal line, and within that there's occlusal table. The recommendation is to make prosthesis that has about 10 to 20% less buccolingual dimension compared with the normal dimensions. If there's no most distal tooth, for instance, if we are providing implant restoration for number 7 or 6, the implant restoration should have 10 to 20% decreased buccolingual dimension. By doing this, you can make an occlusal table that is subject to less occlusal force. Also, because the supporting periodontium is generally smaller than when a natural tooth is present, a smaller implant restoration is recommended. Such design is preferable. Next, the anatomical form of the occlusal surface that is in contact with the opposing arch is very important. As we all know, the inclination angle of the implant crown cusp and the height of the cusp should not be excessive. The screw hole should not be too far away from the occlusal table. And that is the way that we should perform occlusal adjustment. We need to make a prosthesis design that is in harmony with the antagonist. When we're providing implant restoration for a missing area, if the antagonist is excessively sharp or if it is impacted, in other words, when harmonious occlusion cannot be made, we need to make an adjustment on the natural teeth on the opposing arch and then proceed with the restoration process. If there is a significant difference in marginal ridge height, we need to take measures to level the marginal ridge height. In the case where there is deep bite or when the posterior support is lost, the upper teeth may be too deep in contact, or there can be other issues. Then we need to increase vertical dimension so that implant restorations can go in. We need to secure space before providing restoration. If the antagonist has issues such as curve of spee and occlusal curve, if the curves are odd, if it does not have natural looking curve, we need to provide partial orthodontic treatment to align dentition and then provide an implant restoration. This can be a solution that we can choose.
수복을 하는 것도 한 가지 방법이 될 수가 있겠습니다.
Next, I want to talk about marginal ridge and proximal contact. I've mentioned that the marginal ridge height should be level with adjacent teeth, and by doing this, we need to make occlusal embrasure space around the implant symmetrical. The size of occlusal embrasure space and gingival embrasure space, adjacent teeth contour, and implant restoration's contour should be in balance and symmetrical. As for proximal contact, in order to prevent prosthodontic complication, this is very important. We need to understand how tight is the proximal contact area. The size and shape can be very important factors. In the posterior area, it can be divided into occlusal third, middle third, and gingival third. In the posterior region, the proximal contact area typically lies at the junction between the middle and occlusal third, and in terms of buccolingual dimension, it is slightly more towards the buccal side. Depending on the upper posterior, upper premolar, lower premolar, or lower molar, depending on the area, it can be more towards the middle third or occlusal third, but in general, it shows such tendency. Please refer this when you're designing your restoration. As for this patient, in the posterior area of both sides, implant restorations were placed, and since then, various discomforts were experienced, and the patient came to my clinic. The patient's chief complaint was that there was pain in gingiva and food impaction and foul odor. If you look at the image, there's a gingival swelling and bleeding. And on this side, there is a bit of space, and you can see that there is space for food impaction. Between the adjacent natural teeth and implant restoration, the marginal ridge height shows significant difference. Periodontal treatment was done, and you can see that swelling has been reduced. The implant restorations are here and here. The marginal ridge height with the adjacent natural teeth are too significant. It's the same here. The difference in marginal ridge height can lead to food impaction. And with repeated food impaction or retention, gingival swelling can occur, as well as bleeding. Also, if you have not provided proper instruction to the patient for cleaning this area due to repetition of such condition, there can be contact opening between adjacent teeth and implant or between restorations. The occlusal embrasure shape of implant prosthesis and adjacent natural teeth should be symmetrical, and the marginal ridge height should be leveled. Another important point is that between natural teeth and implant restoration, we need to bear in mind the contact area. I've talked about how position, size, and contour were important. If you take a closer look here, there's only contact at one point. And on top, there is slight opening. From occlusal table, through floss, you can get a tight sense, but occlusal embrasure is very tight and deep. By making the occlusal embrasure contact area similar to that of adjacent natural teeth, contact area can be changed to surface contact. That should be done to make it more favorable. From occlusal table, this kind of contour should be provided to provide appropriate contact tightness and contact area to prevent food impaction. In natural teeth, at times, patients show significant wear in the occlusal table, and adjacent surface also show significant wear. Because of proximal surface attrition, you can frequently see significantly wide contact area being formed amongst natural teeth. As shown, it can look crooked or angled. It can be misaligned like a Lego puzzle, presenting a contact area with an irregular shape that is challenging to replicate with a prosthesis. Even if the original natural teeth had very confined or limited buccolingual embrasure and had a significant contact area, we need to form appropriate embrasure space and we need to manage the contact area size as well. This is very important. In order to do that, before we take impression or scan, we need to do thorough inspection of the contour of adjacent teeth on both sides before taking impression, so we can get an understanding on the contact area direction, as well as whether the contact surface is flat or convex. If it does not, we need to do appropriate contouring and polishing to make appropriate contact area surface. After that, we need to take impression and proceed with prosthesis fabrication. By doing this, we can prevent difficulties in making adjustments. By doing this, we can avoid putting in double effort. Next is gingival embrasure space. Compare with the embrasure space in between natural teeth. Embrasure space between natural tooth and implant can be slightly bigger. In order to reduce embrasure space, if you increase the implant prosthesis connector size too much, then the interdental space will be blocked so much so that proxa brush cannot go in. In that case, it can be very unfavorable for maintenance. We can think of instances where embrasure space is completely blocked when there is limited space just to allow for interdental toothbrush to go in, and when the embrasure space is large as in natural teeth for implant prosthesis as well for periodontal patients. In terms of food retention and food impaction, I think it can be more favorable to prevent food retention from the buccolingual side, but in terms of perio management aspect, rather than this, we need to open minimal space for long-term maintenance. It will be more favorable. Even if we block this space 100% like this, it may appear that upon delivery it looks blocked, but this will not prevent food impaction forever due to certain event with progression of time. Once a food impaction occurs, self-cleansing will not be possible, and in that case, it will serve as reservoir and inflammation will continue to occur in that area. Because there is no escape route for the food to get out, there will be continued inflammation on the gingiva and periodontal issues may continuously arise. Rather than this design, we can consider the following two designs when making gingival embrasures. As for embrasure space, we need to make prosthesis, and when we deliver it, we need to check it and continuously maintain it. Gingival form changes continuously, and we need to check it regularly. The gingival embrasure space of the implanted prosthesis sent from the lab can often be blocked. We need to communicate with the lab technician, and we need to open embrasure space as much as the adjacent teeth. We need to communicate this, or else we may have to deliver after making adjustments at chair side. We need to provide clinical images of adjacent teeth to the lab so that the lab can have an idea of what kind of embrasure space the prosthesis should have in accordance with adjacent teeth. When we do regular recall after implant prosthesis delivery with time, this area can be blocked although it was originally open. There can be no hygienic issues, but there can be cases where there is gingivitis. In that case, we need to remove prosthesis and form embrasure space and form space for a proxa brush to go in and continue on with maintenance care. This is something that we do regularly for implant prosthesis. You can see here that there is peri-implant mucositis, so the prosthesis was removed, embrasure space was secured, cleansing was done, and placed again. This is a regular maintenance care program to minimize gingival issues. In this case, upon delivery, embrasure space was not blocked, but now it's blocked, so there's bleeding, inflammation, and odor. Prosthesis was removed and embrasure space was opened. Continuous prosthesis adjustments were made, and continuous follow-up was ensured. As of late, when making implant fixed prosthesis using custom abutment and zirconia crown, I requested the lab technician to provide an opening of a vertical space of at least 2 mm from the gingival line to the superior embrasure. The average thickness of gingival or distance to the bone level is about 3 mm, and we need to open at least 2 mm of space to ensure over 5 mm of distance from crestal bone to contact area. As we all know, based on Tarnow's rule, if the space of over 5 mm become less than 5 mm, papilla fill occurs. In the posterior area, more than aesthetics, it is important to enable self-cleansing. Such distance and space needs to be secured. Then even with time upon recall, the space will not be fully blocked and proxa brush can go through like this. We need to open 2 mm of vertical space for posterior area where aesthetics is not as important. That is the recommendation. Next is about subgingival contour and emergence profile. This is related with periodontal health. The contour of prosthesis can be divided into supragingival and subgingival contour. In the case of subgingival contour, it can be divided into critical contour and subgingival contour. From the platform, subgingival contour should have concave shape, and the critical contour on top should show slightly convex shape. Subgingival contour area should be slightly concave. This allows for transmucosal seal volume to be increased around connective tissue area so soft tissue volume can be maintained in a stable manner. In the case of internal type submerged type implant, which is used most frequently, the recommendation is to place it slightly deeper in bone level, and in that case, from the platform, the abutment goes up like this. If it becomes flat or convex, if the implant has been placed slightly deeply, there can be interference with the bone. The abutment connection can be more favorable when it is more concave. Critical contour or subgingival contour, which starts from the platform, is very important in the anterior area for aesthetic results. In the posterior area, the significance lies in functional aspect. If the contour is lacking, the food can go into the sulcus and cause inflammation. If it is over-contoured, the food will go without going through the cervical area, and because this area is concave when doing teeth brushing, it will not be properly done because of the undercut, leading to significant plaque accumulation. We need to find the right contour which is not excessive or under-contoured. We have talked about design of posterior implant prosthesis. I've talked about proper dimension of implant crown mesiodistally and buccolingually. And it should have an occlusal plane that is harmonious with the opposing teeth. If necessary, prosthodontic intervention can be done so that it can have harmonious occlusal plane with antagonist. Also, we need to either level the marginal ridge with adjacent natural teeth, or if there is significant difference and cannot be addressed prosthodontically, we need to at least make it transition naturally. The contact area space with adjacent teeth should neither be too broad nor too narrow. It should have appropriate contact area space. As for emergence profile, it is related to periodontal health, so as mentioned, we need to make it slightly concave and then convex. Such emergence profile allows for more functional and healthy periodontal condition. In today's session, I have addressed the design considerations for implant prosthesis in the posterior region. Today we have explored the core concepts, though brief, in depth, and if you're interested in more specifics, please refer to offline master course. I look forward to your interest and participation. Thank you.